Welcome back. Let's continue our discussion about cognitive disorders, starting with how we might recognize them in the field. When you arrive on scene and suspect altered mental status, how do you systematically assess it? It starts with the basics level of consciousness. Use the tools you know AVPU, alert, verbal, pain, unresponsive, or the Glasgow Coma Scale if needed for a more granular score. If someone isn't alert, like they respond only to shouting or pain or not at all, that's a sign of a severe alteration, maybe more like a coma or obtundation, which could indicate things like stroke, overdose, etc. But if they are alert, eyes open, looking at you then need to see if they're alert and oriented. So ask your orientation questions person, place, time, event. What's your name? Expect they know themselves. Even in pretty severe dementia, they often know their own name, at least in early stages. Do you know where you are right now? Home, store, city, etc.? Do you know what day it is or about what time? Time is often the first lost. A delirious or demented person likely won't know the exact date. Do you know what's going on? Why did we call the ambulance? To gauge if they understand the situation. If they miss some, note it. Sometimes we simplify. If someone knows person and place but not time or event, we might say alert and oriented time 2, person and place only. If none are correct, they're not oriented at all, definitely altered. If all correct, mental status is pretty intact at that moment, though you still have to be vigilant for less obvious confusion. History is huge. If there's family, caregivers, or witnesses, get a sense of the patient's normal mental status. Is this how Mr. Jones normally is? If they say, oh, he has Alzheimer's, he's usually a little confused, but he's much worse today, that's a clue. Baseline dementia, but possibly acute delirium on top. If they say, no, he was totally fine this morning, this is all new, that's likely an acute issue, delirium, stroke, etc. If nobody is around, look for clues. Medical alert bracelets, memory impaired, or Alzheimer's, or perhaps documentation, a list of meds for Alzheimer's, etc., that suggest a history of cognitive issues. Also check the environment. Lots of pill bottles, polypharmacy can contribute to AMS, or signs of poor living conditions that might hint at chronic issues. While assessing mental status, simultaneously do your critical medical checks. Vital signs, especially temperature, fever suggests infection, a common delirium cause, blood pressure and pulse. Very high or low BP could affect brain perfusion, pulse for arrhythmia, oxygen saturation, low O2 can cause confusion. Always check blood glucose early in any AMS patient. Hypoglycemia is easy to fix and crucial not to miss. Look for signs of trauma. Could this confusion be due to a head injury? Perform a race exam for stroke if appropriate. Basically, differentiate if this is a primarily metabolic or toxic problem, likely delirium, or a focal neurological problem, like stroke. As you interact, take note of how the patient engages. If they're delirious, you might observe that they cannot maintain a coherent conversation. They might start answering your question, then trail off or talk about unrelated things. They might see objects that aren't there or be very fearful. If they're in a dementia baseline, they might be conversational, but give you wrong answers confidently or seem to be living in the past, like thinking a deceased spouse is still alive. Dementia patients often try to cover their deficits, for instance, answering sure, sure vaguely or joking to deflect memory issues, whereas delirious patients often can't even execute that because their attention is so impaired. In summary, recognizing AMS is about checking consciousness, checking orientation, and identifying any red flags that point to causes. By the end of your primary survey, you want to be thinking, is this likely a delirium, an exacerbation of chronic dementia, or something else entirely, or a mix of these? Often it might not be crystal clear, and that's okay. Just treat what you find and err on the side of assuming an acute cause if there's any doubt. How we interact with an altered patient can dramatically affect the outcome of the call, both in terms of patient cooperation and safety for everyone. These patients might be confused, frightened, or paranoid. Our goal is to de escalate and build a bit of trust so we can assess and treat them. Here are some key strategies. First, remain calm and kind. Patients often mirror our emotions. If we're rushed, loud, or visibly frustrated, a cognitively impaired patient will pick up on that, and it can amplify their confusion or combativeness. Approaching with a calm, gentle demeanor helps soothe. Even if the scene is challenging, try to keep your voice steady and reassuring. Always introduce yourself and explain at a basic level what you're doing. Remember, a patient with dementia might not remember your introduction 2 minutes later, so you may need to reintroduce or remind them a few times. That's okay. Repetition and consistency help. For example, my name is Megan. I'm a paramedic. I'm here to help you. Okay, Mr. Smith? Then, if a few minutes later he looks scared and asks, "Who are you?" calmly say again, "I'm Megan, a paramedic. I know you're confused, but I'm here to help." The idea is to ground them as much as possible in the moment. Never argue or harshly correct a confused patient. If a delirious patient insists something that isn't true, I have to go pick up my kids now when they're actually in a nursing home, for instance, telling them flat out, "No, you're wrong. That's crazy. You're not making sense," will likely make them upset or combative. Instead, use a technique called validation and redirection. Acknowledge what they're feeling without reinforcing a dangerous delusion. For example, they say, "I see spiders everywhere." Instead of, "There are no spiders, you're hallucinating." Try, "That sounds scary. I don't see the spiders, but I know you do, and that's upsetting. We're going to make sure you're okay." This way, you're not playing into the hallucination, but you're not dismissing their experience either. If a dementia patient says, "I need to go home to take care of my mother," and you know their mother is long deceased, you might say, "We'll make sure everything is okay. Don't worry. Right now, let's take care of you, and we'll have someone check on your mother." Often they'll go along with that and soon forget about it as something else grabs their attention. The key is kindness and deflection, not confrontation. Body language is important too. Imagine being an elderly person who's already confused, and suddenly two big strangers in uniforms are hovering over you asking questions. It can be terrifying. So, whenever possible, get down to their level. If they're seated, pull up a chair or kneel, if it's safe to do so, so you're making eye contact at the same level. This is less intimidating. Keep your movements slow and deliberate. If you need to touch them, like to take a blood pressure, explain it first. "I'm going to put this cuff on your arm to check your blood pressure, okay?" And do it gently. If they pull away, don't force it immediately. Back off and try to reestablish calm rather than wrestling with them, unless absolutely necessary for safety. Use simple language. Complex medical jargon or long explanations will go over their head and could increase confusion. Instead of, "We suspect you have an infection causing metabolic encephalopathy," say, "We think you might have an infection that's making you confused, and we're taking you to the hospital to get help for that." And one step at a time, if you bombard a patient with a series of instructions or questions, they may only catch the first or last part and get flustered. So, one thing at a time. "Can I listen to your lungs with my stethoscope?" "Okay, thank you." Then do it. Then, "Can you take some deep breaths for me?" "Good." Then move to the next step. Reassurance is big. Imagine how disorienting it is to not know what's happening or to believe something incorrect, like thinking you're in a strange place when you're actually home or vice versa. Frequently reassure the patient, "You're safe. We're here with you. We won't leave you. We're going to help you." Even if they don't fully grasp the words, a reassuring tone can provide comfort. If family or caregivers are present, leverage their knowledge. They might tell you, for example, "He's hard of hearing in the left ear," or "She gets very anxious if you mention going to the hospital. Better to say we're going to see the doctor instead." Little tips like that can build trust. They can also help you communicate. Sometimes having a familiar face nearby calms the patient. If appropriate, you can even have the caregiver ride along in the front or back, depending on local protocols, to keep the patient calm on the way. If a family member isn't present, see if the patient has something like an ID bracelet or wallet card that might have emergency contact info. Getting a familiar person on the phone can help soothe the patient. "Listen, your daughter's on the phone. She wants to talk to you." Also, remember some confusion can be due to sensory deficits. If the patient's glasses are on the bedside and they can't see well, the room might look scary and unfamiliar. Put their glasses on. If their hearing aids are missing, they might not understand what you say and grow paranoid. See if you can find them or speak clearly in their better ear. Many older patients have these issues, and delirium can be worsened by unfamiliar sensory input. Finally, control the environment to the extent you can. A quiet, well lit, but not glaring environment with minimal distractions will help the patient focus on you and not get overwhelmed. If the scene is hectic, with either lots of people or noise, try to move the patient to a calmer area or ask others to tone it down. In the ambulance, avoid running sirens if not absolutely needed for a critical transport, because the loud noise can agitate someone who's already confused. If the patient gets agitated by looking at the IV or monitor, maybe cover it or position yourself to block it from their view. These small things can reduce triggers for confusion or panic. By using these communication techniques, we often can avoid the need for force or heavy sedation. The patient might never be fully oriented with us, but at least they might cooperate enough that we can assess and transport without a big fight. Management of a patient with cognitive impairment or altered mental status is a mix of medical treatment and supportive care. Let's break it down into on-scene and transport considerations. On scene, your priorities are the same as any EMS call: ABCs and treat life threats. The challenge with AMS patients is that their behavior might make assessment tricky, but you still must ensure they're oxygenating and perfusing. If the patient is so altered that they can't keep their airway open, like a very lethargic or nearly unresponsive patient, you may need to intervene. Airway positioning, suction, maybe an OPA or NPA, or even intubation in extreme cases. Most delirium or dementia patients will be breathing, but check if it's adequate. For example, a septic delirious patient might be hyperventilating, blowing off CO2, or an opioid overdose could be hypoventilating. Give oxygen if there's any doubt. Sometimes just correcting hypoxia can improve mental status significantly. Glucose, I'll emphasize again. Hypoglycemia is a quick fix. Always check a blood sugar early. If low, administer glucose, oral glucose if they can protect airway and follow commands enough to swallow, or IV dextrose if not. Diabetics can appear delirious or stroke like when hypoglycemic, and they often make a dramatic recovery with sugar. Consider other quick treatments. For example, if you suspect narcotic overdose, maybe you found pill bottles or there's a history, and they have an impaired respiratory drive, naloxone can be given. Or if you find the patient extremely hot and suspect heat stroke, start cooling measures. If they're seizing, post-ictal confusion can mimic delirium. Handle the seizure, benzos if still seizing. Treat what you find. Pain management. Is the patient in pain? Pain can cause agitation or delirium, especially in an elderly person who can't articulate it. For instance, a patient with a hip fracture who also has dementia might just be moaning and restless, which could be interpreted as delirium. Effectively treating their pain with cautious doses of analgesics might significantly calm them and clear their head. Once immediate issues are handled, focus on that calm environment and communication we discussed. This is part of management too. A calmer patient is less likely to deteriorate or injure themselves. It's best if you can avoid restraints and sedation by using verbal techniques and environment control. Sometimes, though, despite our best efforts, a patient is just too agitated, maybe a delirium from something like PCP or just severe agitation from any cause. If they are putting themselves or you at risk, thrashing so much they could fall off the stretcher or they swung at your partner, then physical restraints might be necessary. Follow your training. Usually that means securing all limbs to the stretcher with soft restraints in a humane way, always supine. Ideally, have enough personnel to do this quickly and safely to avoid prolonging a struggle. Monitor their circulation on each restrained limb and keep talking to the patient calmly during it. I'm sorry, we have to secure your arms because we don't want you to hurt yourself. We're not going to hurt you. They may not understand, but say it anyway. Tone of voice matters. Use of restraints is a last resort, and always continuous monitoring afterwards. A restrained, confused patient could choke on vomit or slip a hand free and pull something, so keep eyes on them. If physical restraints are not enough to calm your patient and keep them and you safe, consider chemical restraint. We discussed that in length in another lecture. During transport, continue all the good communication and calming strategies. Explain noises or movements. We're hitting a bump now. Some patients might get more confused once the ambulance starts moving. Motion plus new environment. Keep them belted in safely. All patients, especially confused ones, should be secured on the stretcher in any position other than prone, both for their safety and yours. If family can ride along and it helps, great. If not, maybe have them follow in a car, but send them with any info the hospital will need. One more thing. If the patient is refusing transport, but you suspect they are not mentally capable of making that decision due to delirium or dementia, this is an ethical challenge. Generally, confusion causes a lack of decision-making capacity, so you may have to treat under implied consent. Each region has protocols for this, but just know that a delirious patient saying, "Leave me alone, I'm not going," might still need to be taken in for their own safety, ideally with law enforcement assistance if it comes to that. Always use de-escalation first, but protect the patient from self-harm. Documentation. Note their mental status exam, what you suspect, likely delirium, possible UTI sepsis, or baseline dementia per family, no acute change noted, any discussions with family, and exactly what you did, especially if restraints or sedation were used and why, patient was combative, attempting to climb out of a moving ambulance, etc. This helps justify that what you did was in the patient's best interest. By following these management steps, we aim to keep the patient stable, safe, and as calm as possible on the way to definitive care. Come join me in the next discussion in this series to review some cases where we can apply what we have learned about cognitive disorders. See you then.